This is a case that is, if I were to give this a title, it is Beware of Mexico, or I would say Beware of Long Distance Dentistry. You want to do dentistry where you're going to finish the dentistry. This gentleman did go down to Mexico looking to save some money, but never had these implants restored. It's been a year. He has not gone back, and now he's looking for somebody to restore this case, but he has not checked the implants, and he's not aware that they may not have healed correctly in his mouth. So the first step is to check them first before we make promises that we can actually restore them. The issue with this case in my mind comes down to what was the surgeon or the person placing the implants, what was the prosthetic that they were trying to achieve? I intuitively kind of know what they were trying to do. They didn't do a great job at that, but there's a lot of discussion and a lot of training in something called all-on-4, or a clear choice model, which is a fixed denture piece to 4 implants. So it's 4 implants, and the problem I have is that the most expensive part is the hybrid part that's going to go on top of those 4 implants. And if you lose 1 implant, it's none on 3. So all on 4, none on 3 is not a very successful long-term solution for spending a lot of money and effort, especially if you have to fly down to Mexico. You still don't save in the end. And here's one of the issues, is that the patient doesn't really quite understand what he was getting into. And I've seen this from patients from India, Costa Rica, Mexico, other doctors even in the area or outside of the area. They find the other implant people out there, and they want to know what their opinion is. So this was intended to be an all-on-4 case, which kind of didn't really turn into that. And one of the difficulties about this case is that particular positioning in the jaw. So if we look at the jaw from this perspective, you have, if this is the midline of the mouth, that means half the teeth go over here, half the teeth go over here. Well, the problem I have is that I have an implant just about in the center, and then I have one implant on this left side, and these are okay, but I would rather have this one further back or this one further in, but this one should be further back, and this one should be a little further back, and this one should be further back over here. So you get a balance. Right now, our balance point across the denture is right across this line, where half the denture is going back here and rocking, and then the other half is being supported by these 2 random implants in the front. Now, if this was a fixed case, your denture piece, or your hybrid denture piece that's reinforced in it, would probably go back only to about this area here. So in the arch, your biting and chewing would go to about here. Now this is about the first molar position right here, and that's where we restore. So it comes up a little bit short as to where we actually want it restored. So the position, the design, the whole thing is all together. I always tell patients, you are coming for the prosthetic. You're coming for the teeth. You're not coming for the foundation. When you buy a house, you don't look at the foundation and go, yeah, I love the foundation, I'll buy it. That's essentially what's going on here. I want implants, you get the implants, but that's just the foundation. The house is the prosthetic. That's what you actually are coming for. So in his case here, let's look at those implants. And he does have bone back behind this. So unfortunately, this dentist didn't quite understand that in the area where he actually needs a lot of the heavy lifting of the support, the patient has good bone, and the nerve, even though there's a constriction here, has enough bone down here to actually handle a nice implant, because he's got D2, D3 bone in this particular area, and that's in that first molar position, like I said. So it would have been really nice to have an implant placed back here, and more in a vertical manner, not in an angled manner, which is the all-on-4 design. But he didn't even have to do that design. The design for that angled implant is to get around a poor IA nerve height, ridge height. So if you don't have space between the nerve and the top of the crest of the bone, that's when you angle it as far back as you can, and then we have tools to make that work with a hybrid piece. So they kind of missed the idea behind angling the implant. Now, on the other side, we would have liked to have seen the implant more here, and that actually looks pretty good too. So they missed an opportunity to put a nice implant in this position, which would have been here, right? Something like that. And then the more ideal spot here would have been a little further back, something like that. And then the patient has decent bone here as well, and then has the nerve there. So the patient could have had the implants placed a little bit more evenly, where this one, this one, this one, and this one would have been a nice locator all-on-4 in good bone and been a really great prosthetic. Now let's talk about the upper. Oh, also in this case, just looking at the X-ray, I'm not sure that this will actually healed up correctly. So he's going to have even more problems, because he's going to be losing this one that he really only has on the left side. This one probably is not good looking at the CT. Now on the upper area here, he has a red in the sinus area. And then he has orange bone quality, and I'll talk to you more about that. But looking at the sinus, you can see here, he only has maybe a couple millimeters of bone here. If you cross your fingers and do sinus lift and add more bone, he has what it looks like enough bone there to generate and help create more bone in this particular sinus area, because this does look like regenerative type quality bone there. So he might be in a good path. He's got 2.5 millimeters. You do a crestal approach sinus lift, add about 3 to 4 millimeters of sinus bone, let that heal for 5 months, 4 months. And now you have about 6 millimeters of bone, which means you can put the implant in and add more graft material in that one event. So that could work out pretty well. But in this case, what we're looking at is, could we place an implant? Well, we could put an implant in here, and that area looks like this, right here, which would require a small sinus elevation. We have enough bone to steady the implant, and we will probably have pretty good success. Now this bone is about more like going closer to a D1-ish, kind of D2-ish bone. So I'd be a little bit guarded, but it would be like a yellow or orange-ish in certain areas. But I think this would definitely work long term. He's got a good amount of bone on both sides, and then you would do the sinus. So if we continued that ability on the other side, here's what you would do is you would look at it somewhere over here, and his bone looks pretty good here. So we would add an implant right into this area doing the same thing. So he would need 2 vertical sinus lifts going up, and it would allow us to place those 2 implants. If you can get those 2 implants, then we'd be looking at 2 more. So here's the ideal situation, is that he would have these 4 implants placed, and they're in a pretty good position, except that we're not in the first molar position. What we would do here is maybe make a overbar with locator attachments on that overbar, and that would be the ideal scenario, where this would be a more long-term solution, and he has enough vertical between his 2 arches to allow it to be an overbar, a locator system here, and then really get that restored really well. So that's how this case would be handled with some of those precautions on board. But it would work. He's got enough bone on those yellow implants. This is a tricky one. This is probably the one tricky one out of it, and that is this implant here, mainly because that bone is really, really solid. And what I don't like, and I'll take a look at that right now, is how homogeneous that bone is. So one of the methodologies, if this is going to take sinus lifts and other things, is that you could do a pre-drill of the implant in there, let softer bone come in so it becomes more regenerative, and then you place the implant later on, 2 months after you do that. So now you have a lot of regenerative bone that's in there while you place the implant, and that should help the whole idea of that implant holding. But otherwise, I like the case, and I think it's got a lot of potential. But of course, what happens is financial resources, limit somebody's ability to kind of maintain this. Now, unfortunately, if he only deals with the bottom here, slowly but surely, fixed or a supported denture on the bottom against a non-supported upper denture can cause more resorption in the upper arch faster. So he's fairly young. He's in his late 50s, and so by age 65 or something, he might have no bone in the upper to actually restore that anymore. It might resorb all the way away. So that's the cautionary tale of that one.